This panel this morning is on molecular influence of thyroid cancer, and I am Maisie Shendo from Portland, Oregon. And this is my co-chair, Dr. Adele Alnegar from MD Anderson. I have three very distinguished panelists. Robert L. Witt, professor of otolaryngology at Jefferson University. Julianne Sosa, who is professor of surgery and medicine at Duke University. And then Alan Ho, who is the medical oncologist, who's an expert on thyroid cancer at Memorial Sloan Kettering. So the goal of this panel this morning is to sort of help present evidence-based data on a lot of this new information that's come out and tools that are available on molecular markers for thyroid nodules. And what I want to do is first bring up Dr. Alnegar, who's going to just give a very brief overview of the molecular pathways. And then I'm going to actually present some illustrative cases and bring up each panelist to summarize some of these different highlights of the cases. And hopefully you guys will be able to take away the clinical applications of these tests at the end of this panel. So, Dr. Alnegar.
Thank you, Dr. Shendo, and thank you for coming this morning. Obviously, what I will do is just give you a brief conceptual view of the molecular analysis in differentiated thyroid cancer. It's not by any means comprehensive, it's just conceptual overview with some of the events that's known to have been characterized in some of these two events. Okay. So, for any kind of cancer, including thyroid, molecular analysis will help sometimes diagnostic, biological assessment and prognostication, and will be useful in current and future molecular therapy or targeted therapy. How we diagnose thyroid nodules, FNA as a first line, and then histology. Both FNA and histology for papillary thyroid carcinoma are not a problem at all. Follicular variant, it depends on how dominant the follicular components are, and there may be very few cases that would be controversial. Most of it would be easily diagnosed. The most of the problem for cytologists would be the follicular lesions, and these follicular proliferative process that may be benign, hyperplastic, or clonal neoplastic, and that would include adenoma, indeterminate lesion, and then carcinoma. Even with histology, the traditional diagnostic criterion for adenoma and indeterminate and carcinoma sometimes it's not set in stone. We really don't know what the biology of these would be. So how tumor develop? We think that perhaps an events, genetics or otherwise, will affect precursor, follicular cell precursor. That could be progenitor, basal cell. I don't like to call stem cell in a somatic sense in that situation. These genetic events will lead directly to PTC, and then additional genetic events may lead to poorly differentiated or anaplastic, or from poorly differentiated to anaplastic. known genetic events that has been established in papillary thyroid carcinoma, most of you, I don't want to preach to the choir, is a BRAF. And the percentage of BRAF depends on the technique, the sensitivity, and ranges from as low as 40% as high as 90%. There are, most of PTC conventional would be having a BRAF and small percentage of the follicular variant. The second most common known genetic event in this is a red PTC, which it happen molecular events that happen either due to translocation at chromosome 10 or inversion. Very variable. It's very hard to have a consistent analysis of that particular events. It's most common in radiation-induced children and also sporadic cancer. So all these events, including RAS, BRAF, RAS, red PTC, will affect the MEK and the MAP kinase pathway, leading to high proliferative rate in follicular cell precursor and the cancer. Therefore, these pathways could be targeted for targeted therapy, and the panel will also address this. For follicular lesions, the evolution is a little bit different. So if we think that the precursor is a follicular cell, there are three pathways. One would lead to an adenoma, which is benign, and will stay as such throughout the lifetime of the lesion, or will lead to adenoma, and this adenoma, with time, will acquire additional alteration and lead to carcinoma, or a third pathway directly into follicular carcinoma. The events that are established in these are RAS and the PAX8, PPAR gamma, and the PI3 kinase pathways. And you could see here that adenoma, carcinomas, all of them have shown alteration in these events. That means that the specificity of these, based on the histologic characterization, may not be as good as we want it. But it also tells you that maybe the histologic diagnosis cannot predict the biology. And if we left the adenoma with this alteration, it may have progressed into a carcinoma. We cannot determine that because the patient comes at one time, we call it by histology adenoma, and may have this alteration, and he could be cured at that time. For poorly differentiated and anaplastic, there are known events that have been associated with these tumors, particularly mutation in the p53 and exon 3 of the beta-catenin gene. So if I will just conceptually summarize the thyroid tumorigenesis as an event that happened in a precursor of a follicular cells, one pathway will lead to PTC, and that would be associated with BRAF and red PTC, and acquisition with additional alteration in B53 or beta-catenin lead to advanced histologic progression. Another pathway will lead to adenoma, carcinoma, poorly differentiated anaplastic pathway, or directly into the follicular carcinoma and histologic progression. I have to leave you with very few thoughts on this. You know, we're going to hear a lot about the molecular alteration, genomics, and progression models and therapeutic panels and so forth and so on. I think we have advanced so far a great deal. I think we have a lot of knowledge on what happened that we didn't know for the last 10 years. But I would warn that before we address the intratumoral heterogeneity of this molecular alteration, sampling may be a critical part that we need to address before we decide on the molecular testing. Second, that we have to decide the diagnostic or biological or therapeutic algorithm that would be appropriate to be used by pathologists, cytologists, and by clinicians. The issue of biological endpoint in differentiated thyroid carcinoma need to be addressed. These patients live for a long time, and they go for surgery after surgery. What would be the use of these biological marker, and what would be the endpoint for that use? I leave you with these thoughts, and we will start our session, and hopefully we could discuss these along the way. Thank you.
Thank you. That was a great overview.